I just started it to get going here so people can see this. And tonight is not going to necessarily be anything that I'm going to present actually how to do them, but I'm going to present why and how I started into doing minimally invasive surgical procedures, and then how what you need to do, what the indications are, what things that you could have to look out for as far as, when it's not going to work, and then, just kind of talk to you about why it's important and why I feel that it's something that we all should be doing. And then I'm going to talk to you guys also about different techniques a little bit here. And we're going to talk more about equipment and the actual procedures for some of these advanced typically surgical procedures that we're now kind of getting rid of. And I guess one of the things that I would tell people is to say that you can't always use minimally invasive techniques. There are times when you can, and there are times when you can't. And so one of the things we're going to talk about as we move through this series of lectures is the fact that when you can and when you can't. And that's one of those things where we really talk about, a hands-on course is just critical as far as being able to know when you can and when you cannot use this. So bottom line, and I'm seeing some people requesting to be in my live video. Sorry, I can't be in my live video, so I'm hoping that is something that is not what you're trying to do. So, but yeah, so I'm seeing people coming in. I'm going to give folks a couple more minutes to kind of get all on here. Most people that are going to join us live, hopefully will have the opportunity to do so. I want to do that before. But just for those of you guys that don't know me, I am Dr. Brook Niemiec. I'm a board certified veterinary dentist. I lecture all over the world. But I think one of the things that's really, really, really important for y'all to know about me and our practice and how we work is the fact that we are practicing veterinarians, and I worked for years as a general practitioner veterinarian, and as a business owner, one of the things that we know is that time is money. And so I think that a lot of that led into our development of these techniques. And there's nothing real magical about it. What I tell people is that if you can take out a simple single-rooted tooth, you can take out any tooth in the mouth, because bottom line is all you have to do is turn everything into a simple single-rooted tooth. So I think it's 2 minutes after 5 o'clock. So for anyone that comes in later, they can certainly watch the first part of this on YouTube. That'll be recorded. So let me start. Okay. Traditionally, extraction procedures, especially of large strategic teeth, basically we're talking canines and carnassials, right? Those are typically the teeth that are big teeth that people generally recommend straight surgical extractions, or open extractions are called now. And that's kind of been going on for decades, as long as veterinary dentistry has been around. And not only that, but there's a lot of veterinary dentists that recommend just making flaps for everything. I mean, as soon as you have a patient that comes in, unless you can pluck them out, they're like, make a flap and drill the bone away. And sometimes that's necessary, and sometimes that's faster, but usually not. And so over the years we have evolved, and it's nice to be seeing some other people doing it this way. But where the minimally invasive techniques have come from is honestly mostly from the human side. When we talk about surgical procedures in animals, we talk about surgical procedures in people. Over the last few decades, there has been a tendency, or a movement towards minimally invasive surgery procedures. And you talk about arthroscopy, laparoscopy, surgical procedures in the mouth with operating microscopes. Pretty much everywhere in veterinary medicine, in human medicine, and human dentistry, everyone is going towards minimally invasive techniques. And the reason for that is numerous. I mean, the biggest one is less pain, right? If you're doing something with a tiny little scalpel blade or with microscopes, you're not making big incisions. And so the big thing is patient recovery and patient lack of patient pain is really one of the big reasons that minimally invasive surgery techniques are so popular on the human side. And also the same thing we talk about is less complications. You know, when you don't make these big incisions, you don't have the chances for dehiscence. When you do these things that are minimally invasive, you know, they just have much less chances of having issues postoperatively. The big thing for us, and the reason that we really like to do them, is just the fact that we just don't have the complications. And I tell people every day when we have courses, and I'm here in San Diego or I'm wherever, Reno next month teaching, when we have these procedures that we're doing, what I tell people is, if you don't make an incision, if you don't cut the gums, and you can take a tooth out without actually incising the gums, there's no place for that flap to go. There's no way for a extraction site to dehiss if you haven't made an incision. And as soon as a scalpel blade enters your hands, that is when your incidence of dehiscence and complications skyrockets. So if we can avoid doing a flap, if we can avoid making an incision, then what's going to happen is that no matter what, even if your sutures break down in the day, right, there's no place for that flap to go, so it's still going to heal. The exception to that rule is if you have an oronasal fistula. If you have an oronasal fistula, it needs to be closed primarily. You cannot leave a fistula open. So a lot of times with these upper canines, we still have to kind of make little flaps. It really depends on what it looks like. If the tissue's healthy and stuff like that, you can avoid making a flap and it'll just kind of close primarily. It'll be fine. If you have a true fistula, that is where I probably would back off of doing it minimally invasive and at least make a vertical incision, one vertical incision, so you can close it without tension. A lot of, when you read textbooks, when you listen to other veterinary dentists, they're gonna talk on and on and on about tension-free closure. Yes, tension-free closure is critical if you've made an incision. If you have not made an incision, then there's no place for that to go. And in our surgeries, in our oral extractions, in us, they don't close them. Why? Because there's a blood clot there. So I do typically suture them so that they can hold that blood clot in so it doesn't get food, it doesn't get debris, it doesn't get stuff like that in there. But that being said, you don't have to necessarily close it, and you certainly don't have to close it without tension, because it's going to granulate in from the bottom up. And so when it granulates in from the bottom up, it heals beautifully. Again, that's where the fistula comes into the problem. When you have an oronasal fistula, there is no bottom to that socket, and so it can't granulate in. It's a bottomless pit. So that is where, when we talk about when can you not use these procedures, which I'll get to in a little bit, when can you not use these procedures? You cannot use minimally invasive procedures without a flap if you have an oronasal fistula, okay, a bottomless pit, and you can't use them when you have ankylosis. Ankylosis is where you cannot elevate ankylosis. As soon as ankylosis enters your world, you cannot use these minimally invasive techniques. You must get rid of you must take bone away, because that's fused to the bone. One of the things that is the reason that we as specialists can do these things quickly is because we know for a fact, or relative fact, this is going to work minimally invasive or it's not. And really, it comes down to two things. Number one, taking a preoperative dental x-ray. If you take a pre-op dental x-ray and you can't see that periodontal ligament all the way around your root, you see that jagged edge and that kind of fuzziness on the edges of that ankylosis, you got to look at it and go, you know what? This has probably got ankylosis. It's probably not going to respond to minimally invasive techniques. That being said, that's not always true. So even if I see that, I'm still going to go after it at the initial part, minimally invasive, okay, without making a flap, but I'm not going to spend very long. If I get in there and I section that tooth and I start working them against each other, or if it's a single rooted tooth, I start elevating, and that sucker's just not moving within 30 seconds, then I'd be like, yep, okay, I'm right, it's ankylotic, jump straight to a surgical extraction. Even if it looks ankylotic on your radiograph, if you go in there and you start moving, and it starts moving pretty well, well, even though it looks ankylotic, doesn't mean it is, so you may be able to take it out closed. So to really kind of talk about these techniques, the biggest thing, if you're going to do extractions without flaps, especially when we're talking about these strategic teeth, and again, 85 to 90% of the extractions in this practice are done without flaps. They're done closed with either just elevating or sectioning and elevating. And so you have to be able to do it right. The biggest problem that I see among veterinarians and technicians in California that take our courses is that they come in and they don't know how to take out a simple single-rooted tooth. It's very common for my office manager to get phone calls for us to see these things. And I kept story after story of veterinarians that have come to me on a course. Because if you guys don't know, we teach basic, closed extractions in the morning and advanced surgical open extractions in the afternoon. And so many veterinarians will go, well, I don't need to come in the morning because I know how to pull incisors. I just need to know how to take out an upper fourth premolar. The reason that y'all might be thinking that you know how to take out simple single-rooted teeth is because they're mostly incisors that are periodontally diseased and they just fall out. So you get away with really poor technique when you have a loose tooth that's lost all of its attachment because of gum disease. Then you get to that fractured upper fourth premolar and you do the lousy technique that you did that you got away with on these periodontally diseased teeth, and it doesn't work. Why? Because the teeth are solid. So what I tell people all the time is if you can take out a simple single-rooted tooth, you can take out any tooth in the mouth. The exception are the lower canines, especially of medium large breed dogs. They tend to get bigger as they go down. They're still a bear. But you typically can get out almost any other tooth in the mouth. And honestly, in my opinion, in my experience, if you gave me the option between taking out 3 upper incisors and taking out an upper fourth premolar, I take that upper fourth every day. Why? Upper incisors are hard, but people think that they can take them out because usually by the time you're taking them out, they're already diseased. So the number one, there's a couple little hints here I'm going to get you, and maybe you guys want to make some of these investments between now and the time we start actually doing these extractions next week. I am a big believer in luxating elevators. I know a lot of you probably use winged elevators, and they're very popular in the dental college, and there's nothing necessarily wrong with them. My experience is that luxating elevators are very sharp at the tip. They're designed to be knife or scalpel sharp at the tip. And what you do is you push in, and you're pushing in as opposed to twisting. When you're using an elevator, elevating is this, That's when you're twisting it. You've got elevation going on. And that is you're not supposed to do that with a luxator because they're very fine instruments. That being said, every veterinary dentist I know that uses luxators twists them. But the first investment I would make, if it was me, would be luxating elevators. Luxating elevators will change your world, especially with cats. And so you're going to see in this course later on, we're going to be using luxating elevators. Why? Because they're faster. And so there's a company, there's tons of different manufacturers. I mean, we have a kit on our site that we sell from Dental Air, but there's a product, Cislak, C-I-S-L-A-K, makes a 1.3 millimeter luxating elevator that's for cats, and for getting these things started is amazing. But you want to have, here's the key, sharp, small luxating elevators. That's the first investment. And if you're going to do minimally invasive surgery, or extractions, whether it is a strategic tooth like we're going to talk about over the next month, or it's just a simple single-rooted tooth, luxating elevators are going to really help. They're less invasive, they're sharper, they're faster, plain and simple. So that's a big investment to make. You can DM me if you want to know more about that information, if you don't have them already. The other thing you're going to need to do all of these things is a very good high-speed drill. Bottom line is, if you don't have a good high-speed drill, you're not going to be able to section the teeth. And what I would use, so you might, again, want to invest in these, I use a 701 usually. It's a cross-cut tape revisor. It's a 701 surgical length, which you got a lot more cutting. You'll see that next week in the presentation. And then small extraction forceps, and then just, and again, we're not doing flaps, so I like a periosteal elevator, we're not doing flaps. So the first thing when you're talking about doing these procedures, and I'll talk to you for just a few more minutes, then I'll kind of give you the reasons why. We'll talk about a few other things. But the first step is to always cut the gingival attachment, and you're doing that with a simple single-rooted extraction or surgical, or these advanced larger teeth. You're basically going to cut the periodontal ligament all the way down to, or cut the attached gingiva all the way down to the bone. So you have to be pretty aggressive. So one of the things that you guys are going to have to get used to use these techniques is pushing in really firmly and twisting gently. And because you want to cut that periodontal ligament all the way around, and that attached gingiva all the way around. And then really, luxators are designed to use what's called on a rocking motion. So you put it in, you just kind of rock it down like that. And that will start getting that elevator buried down further. Once you get that elevator buried down further, then it's going to, I'll give you the opportunity to get a little bit larger elevator in there. But one of the big things I always talk about with minimally invasive techniques, go small. The smaller the elevator you have, the less pressure you need to put on, and the less trauma that's going to be created when you're doing these things. So that's the equipment side that you need to do. And then what we really like to do when I'm doing these procedures is I typically put the patient, if it's a maxillary tooth or the mandibular canine incisors, I'll have them in dorsal. The mandibular cheek teeth I would do in lateral. It doesn't matter. There's nothing magic about that position. It's just more comfortable for me. But if you're more comfortable in lateral, that's totally fine with me. I don't really care. But why do we do these minimally invasive techniques? What are the things, and what are kind of some of the steps as we'll talk about as we present this? Well, we talked about already, for those of you guys that missed it, by far and away, the number one reason that I, in our group, like minimally invasive or recommend minimally invasive is less pain for the patient. I mean, if you're making big flaps, if you're drilling bone away, it is significantly more painful than it is if you do it minimally invasively and you don't expose bone, because drilling on bone is horrifically painful for these patients. So that's the first thing, decreased pain. Number two, maybe more importantly, probably about the same, is less complications. Like I said at the beginning, if you make an incision, that flap can dehiss. If you don't make it a flap, it can't dehiss. And it doesn't have to be closed primarily. Another thing that's really nice about these minimally invasive techniques, as you'll see as we go, they're fast. Just suturing takes so long, especially if you've made a pedicle flap with 2 vertical releasing incisions. Those 2 vertical releasing incisions, suturing them is going to take 10-15 minutes. For us, honestly, I've been timing myself, because we are doing, oh, by the way, we are doing studies on these techniques just so we can prove that they are effective. Taking out an upper fourth in general is about 2 minutes, maybe 3. Canines are about 1.5 minutes. I mean, they really don't take very long. And some of these are perio, but some of these, I mean, I had a dog yesterday. It was a 50-pound dog. It just had a fracture, right? It wasn't periodontal disease at all. And I think it was 2.5 minutes or something like that. And that includes closure. Doesn't include the x-ray time, but it includes closure. So these things can be really fast. Again, one of the things you have to learn to do this effectively is you need to learn how much pressure that you can put on that periodontal ligament before the tooth breaks. Sadly, ladies and gentlemen, the only way to learn how much pressure you can put on a tooth before it breaks is to break a few. And I tell people this all the time. Everyone gets completely freaked out about breaking roots. And I get it. I hate breaking roots. I do a cursing dance every time I do. It's less than ideal too. But the thing about it is, if you're never breaking a root, if you in your career never break a root, then you're not twisting hard enough. You're not elevating enough. Because if you're not breaking some, then you're leaving pressure behind on so many other teeth, and it's taking you a lot longer. And that is the other thing that we talk about with minimally invasive techniques. Less surgical time, less anesthesia time. Because the bottom line is that the faster you get these teeth out, the less time that pet's under anesthesia, which is best for everybody. It's also good for you. It's good for you ergonomically. Again, good equipment, good positioning. If you're doing surgery less time, you have less ergonomic issues. And from a financial standpoint, it's better because it lets you do other things. It's less stressful for everybody. So when it comes to these techniques, we are going to cut the gingival attachment. We are going to section the teeth. But really, and this is where it came from. So I'll just tell you where all of this kind of came from. So Dr. Sept and I published an article, I think 3 or 4 years ago, on extracting the upper first molar. So the big upper first molar in dogs, not the carnassial, but the upper first molar. And it was met with so much resistance from the reviewers because they're like, oh, you can't do it this way. Well, we've been doing it this way forever. It works fine. So we did it. We finally got it published. And then one day, one of my residents was doing an extraction of an upper fourth, and I think it was a pit bull. And I walked back, and she didn't have a flap. And I was like, what are you doing? And she's like, I'm taking out an upper fourth. I'm like, but you didn't make a flap. And she goes, I know. She goes, you didn't make a flap for the upper first. This is just a slightly larger version of an upper first. If we don't make a flap for an upper second premolar, which is 2 roots, and we don't make a flap for the upper first molar, which is 3 roots, why do we make a flap for this? And I was like, oh, because it's what we've always done, right? We've always made flaps for this. We can't. And then I was like, well, what the heck? So this is about a year ago. And I'm like, well, let's try it. It's no different than taking out a 2-rooted premolar. It really isn't. One of my other residents has got a study going out on not making flaps for lower first molars too. So we've got a study published on the upper first molar, and we have a study that's in the works that's been submitted for publication for the lower first molar and deciduous teeth. No, we don't make flaps for deciduous teeth unless they're broken. So that's the other thing about it. Now the last kind of part, because I've been going for 20 minutes, which is about what I expected to. I can chat when I do that. And I'm going to try and go back and look at some of these questions here that I'm getting at the end of this. And if you have questions, go ahead and send them to me. I'll try and get to them here before I go. And oh, by the way, when I do this next week and after that, we're going to have someone that will call out the questions so I can answer to them in real time. But the other thing, what we talk about when we do these extractions, we don't debride the granulation tissue. We don't. There's no reason to debride the healthy granulation tissue. I've said this a million times. The granulation tissue that's in these infected sites is inflamed. It's inflamed and it's mad because the tooth is infected. I tell people all the time, the tooth is the root of all evil. When the tooth is gone, the infection goes away. End of story. It does. And so on the human side, the studies have shown, if you do it minimally invasive as opposed to taking the granulation tissue away and taking bone away, that it heals faster, that it has less pain, and that you get more bone. Because what I tell people all the time, this is the big thing, when I tell people that the granulation tissue is critical. Why? Because the first tissue that forms in any surgical site, whether it's going to heal by primary intention or secondary intention, the first tissue that forms in any site is granulation tissue. And so the problem is, if we go in there and we debride this granulation tissue, we're delaying healing because we're just making the body have to create it again. And when they do that, you also expose the bone, which creates significant pain, and it also creates an area that the bone gets denuded. Another thing I will tell you about this, and people ask me all the time, what about bone grafting? No. The answer is basically no, because there's nothing better than a blood clot. It's got everything in it. And that comes from my uncle, who's the human periodontist, was one of the pioneers of implants. You don't need to do it. You don't. I mean, if you want to, you can. I'm not a big thing, but I don't use bone grafts in these things. So bottom line, I'll just bottom line this, and I'll kind of go back and scroll through and see if I can answer some of these questions. When you're doing these extractions, the key is, and I'm going to answer one of the questions, small, sharp elevators. I like a luxating elevator. That's all I use are luxating elevators. And I generally have a 1.3, that's from Sislak, C-S-I-L-I-K, and no, I'm not paid by them. And I like a 1.3, I like a 2 and a 3. That's really all I use. You should not need anything larger than a 3 millimeter luxating elevator, other than for maxillary canines and large breed dogs, so I will have a 5 just because. And then that's really the biggest thing. Small breed extraction forceps are really nice. And so from that standpoint, that's basically the equipment you need. Take preoperative x-ray. If you see obvious ankylosis, don't spend a lot of time trying to do it minimally invasive. Ankylosis means you got to make a flap and take bone away because you can't debride it. Lower canines of large breed dogs, typically you're going to have to make flaps and take bone away because it gets wider as it goes down. But what I tell people is that, you know, if you're doing if you're doing, let's say, a carnassial, maxillary carnassial, all you're doing is you're taking a 2-rooted teeth and you're making it into a 3-rooted tooth. Or, you know, same thing. If you got a 2-rooted tooth, you cut it in 2 pieces. You got a 3-rooted tooth, you make it into 3 pieces. Trust me, the techniques that we use to take out simple single-rooted teeth are the exact same thing we do when we've cut a carnassial into 3 pieces. It's no different. And yes, I know when you close that flap, it's not going to close edge to edge. It won't. But I can tell you what, if you come back in 2 weeks and recheck it, it's going to have granulated in and it's going to look beautiful. Again, as long as you don't have an oronasal fistula in there. So I'm going to scroll back here and answer some of these questions. If you guys have more questions, you know, please text them to me. I'll stay on for a little bit longer and answer this, but you can always DM me later. Somebody had asked, do I use a peritome? I don't. There's nothing wrong with a peritome. A peritome is an instrument that basically acts like a jackhammer with an elevator. I will be honest, and my female residents really like it for canine extractions. They do a really nice job because they don't have the hand strength. No offense, ladies. My male associates and I, we don't find that it's really any faster or less invasive than what we're doing already. But if you have issues with hand strength, like if you're getting into arthritis, or if you don't have a lot of hand strength, if you're struggling with these canines, then certainly a peritome would be something that would help you guys out. I think I answered the question about the instruments. I mean, really, it's just luxating elevators and small ones, little ones. You know, and I know I got big hands. I know I'm a big guy, but I really those small. Remember, the smaller the elevator they use, the less surface area. So that's less pressure you need to develop that PSI. To be honest, no, I do minimally invasive. Somebody had asked if I can do it with solid teeth. Absolutely, I can. And the example that I'm going to show you next week, God willing, if everything goes well, it's on live Instagram. But honestly, no, we do it for anything. It's always easier when you have period loss, but we do it all the time. As a matter of fact, I did it yesterday in a cat with stomatitis for the upper canines, and it worked beautifully well. And again, no, they're not going to close primarily, but they do really, really well. I'm going to go ahead and scroll back in here and see if there's any other questions from anybody. It doesn't look like it. Looks like I've answered the questions that people have asked. I'm going to scroll back down to the bottom and see if there's anything. Yeah, I'm not sure why the luxators that you have wouldn't fit into the periodontal ligament space. I mean, really, you should only be using about that much of it. So I don't know if it's a brand issue or not. I can tell you that all the luxating elevators I have are pretty thin, and they should be knife sharp, so it shouldn't be. I mean, yes, they do get bigger as they go up, but really you should only be needing to use about 1 centimeter of it. So that I haven't seen. If you want to take a photo of it and DM me later on, I'm happy to kind of take a look at that from those there. No, actually, no. A question came in: will the bone atrophy without a bone graft? Not really. You might lose a little bit of crustal bone, but honestly, that bone will fill up. And I was just reading something that came from Dr. Hernandez's study that he's publishing on the lower first molar, and really, there's bone back in that site in like I think it was a month and a half. There's already like bone there, so there's not really much that's going to help it to grow. And I think a lot of the things that we worried about were on the human side when they talk about the alveolus collapsing. honestly, I haven't really seen it in dogs, and I've been doing it a long time. Yes, we are accepting residents. The best things to do, basically anyone that's interested in a residency here in our practice, yes, we take residents all the time. Generally what we do, if you go onto our website and you look up the residency, there's a video that talks about the residency program, and it also has things that are lined out about what you would do and what you think. And really, if you want to apply, I will tell you one thing, there's probably some international folks here. Unfortunately, and I know Dr. Kitty knows all about this, she's on here. Unfortunately, unless you're licensed in the United States, you can't do a residency here because you just can't work here, unfortunately. The only way if somebody is foreign and wants to do a residency in America, you have to go to university, because universities can take people that are not licensed in this United States. In America, you have to be, in a private practice setting like ours, you have to be licensed in America. Obviously, we can work with you on that, but it's a long process to try and get that done. If you're in Europe, there is the possibility for a part-time residency, and I am a diplomat in Europe as well, so is Dr. Furman, or at least he was until recently. I'm not sure if he's kept that up or not. But I mean, we could do a European one, but unfortunately an American one. So if you guys want to do a residency, if you want to be interested, the first thing we say is fill out an application, send it to us with 2 letters of recommendation. If we'll talk on the phone, we'll do a phone interview and say, this, tell you what exactly you have to expect to get into a residency, what are the pros and cons, and then if we like each other, then we generally recommend you come and spend a couple weeks with us. Come and spend a couple weeks in our practice, whether it's here or up in Irvine with Dr. Furman, and just get a feel, just talk to our residents, talk to our staff, and we'll talk to you and you say, this is how your life is going to be for the next 3 years. I tell people all the time, dentistry is actually a fairly, I hate to say this, but it's fairly easy. It's not that tremendously hard. People get freaked out about it, but after you've been doing it for a while, it's not scary. And the other thing that's kind of nice for me is that it doesn't take a lot of book smarts to be a good veterinary dentist. There's certain things you need to know. We need to know why we do certain things. But I tell people all the time, there's no way I can be an internist or an oncologist. I'm just not smart enough to do that. I think that's what instrument size do you use when doing the wheel and axle? I generally, it depends on the size of the tooth, but that's a great question. She's asking about the wheel and axle, and when I get it up underneath that ledge, what I typically will use, it again, it really depends on the tooth, but usually either a 3 or a 5. I mean, you can use a 4 as well, but you have to use a little bit bigger one, so you're kind of getting that up underneath the gum and getting that twisted. But yeah, usually a 3 to 5 minutes, and those, and actually, to be honest, winged elevators work really good for that. I just don't happen to have any, but if you do have them and you want to switch over to that for that wheel and axle, that's really, in my opinion, the number one thing that you could use for that. So I think that's all the questions that I have. So it's been a half an hour, which is exactly what I wanted to do. So that's your introduction to why we do minimally invasive, kind of some of the equipment that you're going to need to do, what the advantages are. And then next week, what we're going to do is I'm going to have a cadaver and I'm going to live. So there's no way I can do like little, whatever stopgap things or like, oh yeah, it really took me 3 minutes to get it out, where it was like 45 minutes of filming and I just edited it. No, I'm going to do it live for you guys. And God willing, again, of course, who knows, the cadaver could end up having, ankylosis, and I could be cursing. But the goal is to do it and to show you guys not only how you can do it, but to prove that it actually works and it actually can be quick and you don't have to make flaps to drill the bone away. But all we can do is hope, and it's going to be live, and live television is always scary. And I'm going to have one of my residents doing this, and also Carrie, so you can ask questions during it. And like I said, if anybody of you guys want to share this to your friends, that's going to be on YouTube. Give me a couple days, but it's going to be on YouTube. And if any of you guys eventually want CE credit, because this is not interactive for the whole thing, at the end, after we've done all 5 towards the end of the year, I'll have some questions online. You can go online and purchase CE things. So anyway, it is 5:33. I went longer than I expected to. I hope you guys enjoyed it. Like I said, it's going to be on YouTube if you want to go back and review this. But next week on the 1st, we'll be doing this, and I believe I'm doing doing upper force to start. Don't quote me on that, but I'm going to be doing one of those next week. So have a great evening or morning or wherever the heck you guys are in the world, and I will see you next week.